The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hi, everybody. This is Tali Speizman.
This is Erinn Kary. Okay. So today we are going to be talking about an article called the 1,000 Norms Project, which is a description of a protocol of a cross-sectional study cataloging human variation. This article was inspired by a post on the Senior Rehab Podcast Game Changers Facebook group by Meg Lowry. So thank you, Meg, for posting this. I thought it was really interesting and worth discussing in a shorts episode.
Yeah, thank you, Meg. It's so nice to see people involved and that we're not just talking to ourselves on mics. Though that would be very cool as well.
Would it?
But it's really nice when people actually react to things that we're saying. So we're always happy to hear what you have to say, hear what you want us to talk about. So thank you, Meg.
Yes. And so if you have an article that you want to hear us talk about on this part of the show, please post it on Facebook or you can send it to us directly. Our email addresses are in the show notes. Cool. All right. This article was published in Physiotherapy in March of 2016, and it's a study protocol description being run by the University of Sydney. So the big idea of this article is the concept of normative data and how it is vastly important to the physical therapy profession. Through performing tests and measures and comparing them to a normative data set, we have the ability to design interventions that address specific impairments and to reevaluate their efficacy, thereby improving our patients' quality of care.
All right. I see it's going to be a big subject.
The author's idea is that having an understanding of what normal variation is can help guide development of future clinical trials. So right now, what we have in our normative data set of many things are that they're often done, that those numbers are often found through small sample sizes of young, healthy adults as the subjects. How would that be a problem to our audience specifically?
That they are young and healthy adults.
Right.
And unfortunately, it's great that we get to see them when they're young and healthy in order to preserve that. But most of the times we don't see them when they're young and healthy.
Absolutely. Right.
I do like the thing about the norms because customers or clients ask, is everybody like that? Am I better or am I worse? And it's kind of like, it's nice to reassure people. There's a decline in function as we get older. It's a normal decline, but it's important to know what is normal decline and what is okay, we need to target that.
Right, exactly. I think you hit the nail on the head with that. We generally know that there's a decline in function of a lot of things as we get older. However, we don't actually necessarily know that. That decline, we don't know what healthy aging looks like in a lot of different metrics. So a lot of these reference values data sets are things about grip strength, range of motion, strength, and gait. And that's it. The authors also brought up something that I think is really, really important. They bring up the fact that most of these data sets that do exist in the data are behind paywalls. So the only people that can access them are researchers in large institutions where the institutions can afford these really large subscription fees to the data.
They are too expensive for us to see.
Yes, right.
Okay.
Yeah. As clinicians who are not part of large academic institutions, we don't have access to this information and we could really benefit from it.
Yep, that's a good point.
Right. Another point that they make in the present state of the normative data is that no single resource containing reference values for males and females across the lifespan for musculoskeletal and physical performance measures exists, which I think is kind of mind-boggling. The authors also bring up this gene called the ACTN3 gene. And apparently this particular gene, it codes for alpha-actinin 3, which may influence athletic performance. However, it's unknown how this gene affects non-athletes. So there's a big sampling bias.
Okay.
Yeah. So they suggest that there's an influence of epigenetic factors, notably physical activity habits, on muscle phenotypes in the elderly, suggesting that genotype is possibly one of the strongest candidates to explain variance among muscle phenotype. In this protocol, along with having all these different tests and measures looking at these different domains of physical performance, they're also doing genetic testing so that everyone's doing a saliva swab. There are two primary aims of this project. The first one is to generate a wide-ranging database of musculoskeletal and neurological reference values in a cohort of 1,000 healthy individuals aged 3 to 100 years. The second aim is to develop predictive equations adjusted for factors such as age and gender for each individual measure. So one thing about this, I actually don't think 1,000 is a lot. What do you think?
I do. Why don't you think it's a lot?
Because these are normative values. There's so much variation in what is considered healthy. So the way they have it set up is that it's approximately 100 people per 10-year age bracket. There's more in the younger ages, which accounts for the drastic changes that happen throughout childhood, but still like 150 to 59-year-olds, there could be a lot going on there.
There could be a lot going on there, and I assume that they're all Australians. Am I assuming wrong?
Yeah, no, you're totally right. So the sample was a convenience sample in the area of Sydney, around the University of Sydney. So they're also saying that this is a interdisciplinary, multi-institutional collaboration of researchers, clinicians, and higher degree students. So in this one, they do a lot of community flyering and advertising. The way they set it up was that every 2 months, they kind of did like an advertising blast of print, radio, and television ads throughout the area until they got all of their numbers for the entire study taken care of. So there are 4 stages of this study. First is the establishment of working parties. The next is a comprehensive review of the definition of, quote, normal, which I thought was quite interesting. What is normal?
What is normal?
I don't know.
I think the politically correct way to say is typical.
Ooh.
At least, like, when I did my bachelor degree, about kids, you were not supposed to say normal development. You were supposed to say typical development.
You're right. In class, the word was always atypical. They identify viable sampling and recruitment strategies. So that's like the advertisement that we were talking about a minute ago. And then they did a selection of clinically relevant, patient-centered musculoskeletal and neurological items to be collected in the project. So those are the outcome measures specifically that they're identifying and using in these populations. So items were considered if there was an absence of high-quality reference data across the lifespan, which most. Next was if they had acceptable psychometric properties. They were feasible in terms of time and equipment. They were measurable across all ages. They had low ceiling and floor effects, and there was minimal risk of injury to participants or examiners. So they started out with 73 different things to investigate, and they came up with 47 total.
Okay, wait. 73 things to investigate. How did it get to 47?
You're right. I actually am not sure. It's a good question. Hey everyone, this is Erinn Kary with a quick side note to answer Tali's question. In the article, the authors state that the individual items to be included in each of the constructs were identified by the 1,000 Norms Project Consortium as those of most interest and demonstrated sufficient reliability and construct validity to represent the construct being examined. Additionally, in Appendix A, there's a chart with references available, although I want to note that in their columns, they don't define what acceptable psychometric properties means. So, thanks for having the patience to listen to my lovely microphone. I'm on vacation with my parents in Florida, so I don't have my fancy stuff. Anyway, back to the podcast. So the recruitment, they worded it as a highly structured convenience sampling strategy, which they would find healthy folks in Australia, but there was some difficulty with that, considering privacy laws protecting health records and personal information, making that pretty difficult. So it's similar to the United States in that regard.
So it's healthy, but you rely on the fact that the person said, I'm healthy.
Right. Yeah. The way that they did that was they asked them 2 questions at first. First, do you consider yourself healthy for your age? And there's a lot of subjectivity in that.
Yeah.
Second, are you able to participate in normal activities of daily life with respect to your age? There were other exclusion criteria such as inability to follow age-appropriate instructions during the physical assessment, insufficient English to complete questionnaires, having self-reported health conditions or factors affecting physical performance, and the presence of the following conditions. 1 is diabetes mellitus, malignant cancers, demyelinating inflammatory and degenerative neurological conditions, pregnancy, class 3 obesity, severe cardiac or pulmonary disease affecting performance of daily activities, history of major surgery affecting physical performance, infectious or inflammatory arthropathies, severe mobility impairments necessitating dependence on mobility aids for ambulation. So there's something really big missing there.
Mental status?
Right. Psychiatric conditions are not exclusion criteria, which I thought was great.
Yes. So right now I work actually in a geriatric psychiatric unit.
Yes.
It's a big influence on the function.
Absolutely. And they specifically said that they did not exclude it because they wanted to have better generalizability of their data set to the healthy population. So they're acknowledging that people with cognitive, behavioral, and mental health issues can still be considered healthy, which I think is pretty powerful. You have thoughts?
It's powerful, yes, but I feel that it's ignoring. It's as much as a condition as diabetes.
I'm not sure I agree.
I like when we disagree. From my experience, the level of impairment is higher with mental illnesses as opposed to, if you have managed diabetes.
I'm with you on that. I think if it's well controlled, you could still be technically considered healthy.
Yeah, some people are well controlled.
Right.
That's with both, any physical condition and any mental condition. There are a lot of people functioning with bipolar disorders, with depressive disorders, with any... I can see why they wanted to have people with mental disabilities also, but it's the same as any other condition.
I think you may have changed my mind to be more on your side, but with the caveat that maybe they should have included people with diabetes who have that well controlled. Like, it shouldn't be an exclusion criterion.
I don't know. I can understand why excluding both.
Yeah, and I can understand why you would include both. Agree to disagree.
Yes.
That's okay. High five. So then the way they set it up was that the subjects would come in for one single appointment where they would complete the physical measures, the questionnaires, and the collection of the saliva DNA. Would you like to hear about the different physical measures that they discussed?
Yeah, what were the different physical measures?
So they looked at anthropometric and structural features. Then they looked at physical performance, and they defined this as the ability to carry out physical tasks. So they looked at these subdomains, which was dexterity, balance, ambulation, range of motion, strength, power, endurance, and motor planning.
So they didn't do any mental or intellectual, like a MOCA or...
Those actually come in the questionnaire. So this is just the physical measures that they did for this. Yeah, but you're right to think ahead like that. So then they have a table that talked about all the different items that they measured in the project, and a link to that will be in the show notes. So the questionnaires looked at knee and ankle function, musculoskeletal pain, physical activity, quality of life, self-efficacy, work capacity, and workability. So like they use the IPAC for physical activity and things like that.
Those are a lot of questionnaires.
Yeah, right. And they had it stratified by age groups. So there are some specifically for children, and then there are some specifically for elderly, which they define as age 70 to 100. This project has been prospectively designed to minimize missing data through careful data collection methods and rigorous data cross-checking. So this is just a protocol. This isn't any data or anything that they've found as of yet. So what do you think so far about their protocol?
So far about the protocol, first of all, kudos for trying to research and give us more information about something that I think we're really thirsty for this information as clinicians.
I fully agree with that, yeah.
Not only as clinicians, as a society.
Yeah, we don't know what typical is.
No, we don't know what normal is. We don't know what typical is. It depends what you prefer to use. And it's a big task to measure it, and really kudos to those researchers who strive in order to spend their money and their time and efforts, and recruiting that many people is not easy.
So this is directly from the article. They state that this project will establish a freely accessible reference dataset of over 50 musculoskeletal and neurological measures of a healthy population aged 3 to 100 years. Data from this project will assist future studies in physiotherapy to more accurately define normal and abnormal and develop norm reference outcome measures in clinical trials and studies of natural disease progression. This project reference database will provide normal values for these outcomes, greatly assisting in the diagnosis of physical impairments and guiding best practice management and evaluation of treatment interventions.
One more thing that I want to say. One of the things that we do know about aging and decline of functioning with aging is that it is influenced by the society and the environment.
I fully agree. And I think that's one reason why they published this article on the protocol, specifically so that other countries could take this and do their own normative data set building.
Okay.
So then, where are they now in their study protocol? So this group of researchers have finished recruitment for the study, and they are in the process of analyzing data from all 1,000 participants. And they have a cute little video on their website. Their website is also in the show notes. And one quote from it that I really think was telling of their priorities for this project was, "We are particularly interested in healthy aging. This data will help us understand what normal is and what normal healthy aging is." And I think that's wonderfully important.
Yeah, I can't wait to see the study itself.
Right. Yeah. When that gets published, maybe we'll do another shorts episode about it.
I think that we will definitely make another shorts episode about that.
Well, thanks, Tali, for coming and learning about this with me.
Thank you for choosing this. I like when you choose things that I know nothing about.
Yeah.
And things that I haven't heard of.
I can keep doing that.
Yes, that will be great.
Thanks to all our listeners for listening to this podcast. And you can find us all on Facebook at facebook.com/Senior Rehab Project. And you can email us at Erinn@jaroscollective.com and
Tali@jaroscollective.com.
Awesome. Thanks again. And as always, stay funky.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoy this content, I highly encourage you to go to seniorrehabproject.com, where you can find more helpful episodes, lots of free resources, and to see how you can become a game changer and influence the direction of this movement. I appreciate you, and I'll talk with you soon. But in the meantime, do not forget to stay funky. The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. This podcast is brought to you in partnership with the Jaros Collective, a podcast network that's redefining old and equipping healthcare clinicians to better serve our aging population. Find out more at GEROScollective.com.